Thank you, Dr. Goldenberg. So this morning I'd like to talk about the perioperative management of patients who are chronically anticoagulated. So this talk is not going to be about DVT prophylaxis. That was sort of covered in the surgical grand rounds back in October. But what I'm talking about is patients who are on warfarin, aspirin, Plavix, who are coming in for surgeries, and we'll talk about exactly how you should be managing them. So what I hope that you'll get out of this talk is that you should know which of your patients needs to be anticoagulated perioperatively, manage the basic perioperative anticoagulation based on the current guidelines, and know sort of an idea what drugs we should be cautious about during anticoagulation. So this is increasingly important to us as urologists for a few reasons. Patients are living longer. Therefore, their need for urological procedures and repeated procedures is higher. Not only that, they're usually anticoagulated or will have some exposure to anticoagulation, mainly because of atrial fibrillation, thromboembolic events, cardiac stenting, mechanical heart valves. And there is, with patients getting older, an increasing polypharmacy that we need to be aware of so that we know what the contraindications and the effects are with different drugs. So what we're talking about this morning are mainly warfarin and antiplatelet therapies, so aspirin, thienopyridines, that includes Plavix and Titlid, or ticlopidine. Okay, and warfarin, of course, is known for being used in atrial fibrillation, mechanical heart valves, or MHVs, and venous thromboembolism, VTE, vents. This is just a little slide. I hope it comes up pretty well, just showing the effects of different anticoagulants. So warfarin is used mainly against the different factors, mainly prothrombin or factor 2. It has some factor 10 activity as well, of course, the vitamin K dependent factors, so 2, 7, 9, and 10. You also have these newer agents, so factor 10A inhibitors, as well as direct thrombin inhibitors. And these agents are usually used for patients who have a history of HIT or heparin-induced thrombocytopenia. And then we also have is my arrow coming up there? Okay, sorry. And then we also have the low molecular weight heparins, which have some indirect thrombin inhibition. And then, of course, your platelets, which come into forming the fibrin clot. So the antiplatelet agents work against those. So let's talk about warfarin management really quickly. So warfarin, as I talked about, affects the vitamin K dependent factors. We have it basically inhibits vitamin KO reductase, which reduces vitamin K to its active form, reduced vitamin K. That is used for gamma carboxylation of the 2, 7, 9, and 10 factors, and those are for newly synthesized factors. So the longest half-life of all of those factors is the prothrombin or factor 2. And therefore, when you reintroduce or when you introduced warfarin, it takes a while for it to get effect. And this prothrombin goes to its active form, thrombin, and that converts fibrinogen to fibrin, which goes on to make your cross-linked clot. This is the extrinsic pathway. So back in your biochemistry, extrinsic pathway, so you monitor your PT, INR. Looking at the coagulation cascade again, you see it's 2, 7, 9, 10 factors that are all affected. So when you're talking about the perioperative management of these patients for elective procedures, you need to always stratify these patients into risk of thrombosis versus risk of hemorrhage postoperatively. So there have been a few guidelines that have come out regarding the perioperative management of antithrombotic therapy. This is in the CHEST article from the American College of Chest Physicians. And this is the 2008 version. This is the 8th edition. There's also on the BC Health Services website, there's these guidelines and protocols which are a little bit outdated. These ones were from 2004, but I've sort of melded the two so that we come to a general practical approach. So just looking at just for your own information, rates of thromboembolism with different indications and what the risk is on without anticoagulation and the risk reduction. So for any VTE or venous thromboembolism, in the first month is always the most deadly month for patients to have a recurrence. So there's a 40% rate of recurrence or risk of recurrence within that first month. In the second and third months, it's about 10% within those 2 months. And then when the patient is on anticoagulation, that risk drops to 80 to 90%. Recurrent VTE, just in general, after those first 3 months, sort of 15% per year, that actually decreases as time goes on, but no one can really say for how long. Arterial thromboembolism, we're talking about non-valvular atrial fibrillation. That means atrial fibrillation that's not related to rheumatic valves. It's about 4.5% per year. Mechanical heart valves, about 8% per year for thromboembolism. And that risk reduction is about 75% on anticoagulation. So it's very important for these patients to be anticoagulated. So as urologists, you have these patients who are coming in, they're on their anticoagulation for whatever, and you want to find out, do I have to bridge this person? What can I do? Can I just stop their anticoagulation? Is it safe? So there have been studies looking at stratifying patients according to thrombosis risk. So there's this thing called the CHADS score that every time we consult hematology or cardiology, they put it on the chart. So CHADS basically is it's a validated method of assessing thrombosis risk in patients with non-rheumatic or non-valvular atrial fibrillation. CHADS basically, it's a fancy way of saying CHF, hypertension, age more than 75 years, diabetes, and stroke. So you give basically 1 point for each of those, except for stroke, which gets 2. So it's out of a total score of 6. And then this has a direct correlation to the risk of thromboembolism from atrial fibrillation. And here you can see in this table the adjusted stroke rate per 100 patient years. So basically, as you increase the CHAD score, there's a higher risk of thromboembolism. So just put it into the categories low, moderate, and high. So high risk would be CHAD score 5 to 6. Also patients who have had in the last 3 months stroke or TIA or rheumatic valvular heart disease, those automatically become high risk. And then moderate is sort of CHADS 3 to 4 and low CHADS 0 to 2 or no history of stroke or TIA. There have also been studies looking at thrombosis risk with the mechanical heart valves as well as venous thromboembolism. So these are sort of stratified again, low, moderate, and high risk. High, automatically, it's any mitral or mechanical heart valves or older aortic heart valves or a recent stroke or TIA within the last 6 months. And then moderate, it's these aortic bileaflet mechanical heart valves with atrial fibrillation. Low would be that same valve without atrial fibrillation. Okay. And then for venous thromboembolism events, so within the last 3 months, as we talked about, the risk is the highest. And if you have a severe thrombophilia, of course, those patients are also automatically high risk. Moderate would be a VTE event within the last 3 to 12 months, recurrent VTE or active cancer treated in the last 6 months or palliative. And low would be a single VTE event more than 12 months ago. So what are the recommendations from these are, again, from the CHEST article back in 2008, which is widely quoted. So for low-risk patients, no bridging is required, no bridging is recommended. You discontinue the warfarin, and if there are an aspirin that's just kind of out there, you want to stop that 5 days prior to surgery and check the INR before surgery. And usually most surgeries, most patients will do well if their INR is less than 1.4. Some people want it normalized completely. That is really dependent on surgeon preference for the most part. And then you restart the warfarin at the preoperative dose as soon as hemostasis is adequate. And there's no sort of a timeline as to when the warfarin needs to be restarted. You just basically restart it. And, there's this, through our biochemistry, we know that when you restart warfarin, there's an increase in your protein C and protein S, which makes actually the patient a little bit more hypocoagulable. But there's no recommendation for these low-risk patients that we need to do anything about that. So again, low-risk thrombosis, CHAD 0 to 2, no history of stroke or TIA, and single stroke event, single DVT or PE event more than 12 months ago or so. Okay, so moderate or high-risk patients, again, below I've listed, just to remind you what moderate and high risk are. Bridging anticoagulation is recommended pre- and post-operatively with either unfractionated or low molecular weight heparin. Okay, and this was a slide taken from the 7th edition of the ACCP guidelines. So we'll just go through it. And the only change has been that instead of the prophylactic dose being used for preoperative bridging, they recommend therapeutic dose instead. So, so you have your risk, okay, it's either moderate or high risk. You're going to stop your warfarin preoperatively. Then you're going to start your low molecular weight heparin or your unfractionated heparin at your therapeutic dose. So you have your procedure. If the patient is at high bleeding risk and they're at high thrombosis risk, or if they're at low bleeding risk and high risk, basically those patients fall into the same category. You want to restart the low molecular weight heparin or the unfractionated heparin at the therapeutic dose as soon as hemostasis is adequate, okay? And they really recommend starting within, or after 12 hours within your procedure, basically, is what they recommend. The other category, so for moderate risk patients, you start them at therapeutic dose or heparinize them at therapeutic dose for bridging. You have your procedure. If their bleeding risk is low, you want to restart them on their heparin at the therapeutic dose. So this is changed in the 8th edition. And then if it's a high bleeding risk, you can either decide no heparin, so no bridging, and just restart their warfarin, or restart their low molecular weight heparin or unfractionated heparin at a prophylactic dose. That prophylactic dose is just the dose for DVT prophylaxis, right, which is usually half the dose. And that is, of course, when hemostasis is adequate, okay? There's no real evidence for the high risk for this group of patients, but it's sort of what is sort of recommended or loosely recommended. So again, we talked about, this is just the going through the actual practical way of doing it. So you discontinue your warfarin 5 days before the procedure. Do not use heparin if there's a history of HIT. If there is a history of HIT, automatically, as urologists, we'll be referring to hematology or the internist to manage them with the other newer agents. Okay, you want to start them on the therapeutic dose of the low molecular weight heparin or the unfractionated heparin. It's about 1, so in patients who've been exposed to heparin, it's about 1%. And it's a little bit lower with patients who've had exposure to low molecular weight heparins. But there are agents, though they're more expensive, that you can use if patients have been exposed. Anybody else? Okay. So, so you want to basically start your unfractionated heparin or your low molecular weight heparin about 36 hours after you stop the warfarin. So this is basically going to be when the patient is sort of, the INR is coming down, and you want to catch them just when they think, so they're not going to be completely, therapeutic on the warfarin as well as therapeutic on the heparin at the same time. So you can either do it 36 hours after if the patient is an outpatient, or you can do it when the INR is at the lower limit of the goal INR range. You want to check the INR the day prior to surgery. That's a big duh. Okay, so this is sort of the practical thing again. So for moderate and high-risk patients, so the low molecular weight heparin, usually in Canada we use enoxaparin or dalteparin pretty commonly. Dalteparin at therapeutic dose, we should all know this as residents, 200 units per kilogram sub-Q daily. Or enox if you're using it, and that's more popular on the hip and ortho side, 1.5 milligrams per kilogram sub-Q daily. Those are usually given for 3 days preoperatively. The last dose is given about 24 hours before the procedure, and it is reduced by half. So usually if you see that prescription that's written for patients, if they've been referred to hematology or so, they give them basically a prophylactic dose the day prior to surgery. If you're doing, unless they're high risk, then they will go, usually they'll do a therapeutic dose actually. For unfractionated heparin, so these are for patients who have a contraindication to low molecular weight heparin. So these are patients who are morbidly obese, so are over 190 kilograms, or their creatinine clearance is less than 30 milliliters per minute, because these are patients who you want to be more well monitored, more invasively monitored, so they'll be getting PTTs all the time. So you want to admit them and start infusion. They recommend 2 days prior to surgery, using one of the standard nomograms, plus or minus the 80 unit bolus, and you want to discontinue that 4 to 6 hours before the procedure. And then you want to restart bridging when, so after the procedure, when there's adequate hemostasis. Okay, you want to maintain the low molecular weight heparin or the unfractionated heparin overlap until the INR is in the therapeutic range for 2 consecutive days. A lot of times that can be done as an outpatient. You can just liaise with the family doctor and they can do that for you. If there's active clinically significant bleeding or indefinite contraindication to anticoagulation and there's a high risk of recurrent venous thromboembolism, you want to consider your IVC filter, and that's when you consider it. Okay. So just a little bit about the heparins themselves. So heparin, all the heparins basically work in the same way. They bind and activate antithrombin 3. Antithrombin 3 basically inactivates your thrombin 2A, which is one of the most potent factors. And it also has effects on 9, 10, 11, and 12. And this is through the intrinsic pathway. So the PTT is the one that's monitored, and that works to decrease clot formation. So this is just a little schematic showing you where it works. The pros of unfractionated heparin is that it has a short half-life. So you stop it, 4 to 6 hours later, you can operate. Okay? It's easily reversed by protamine sulfate. So there is an antidote, and it can be well used in patients with severe renal failure or morbidly obese patients. The cons of it, of course, is that it is expensive to admit a patient. It is inconvenient for patients. You need invasive monitoring. You need the PTT to be going on. And there's a less predictable dose response. So that is mainly the reason why you have to monitor these patients' PTT. 1% risk of HIT. And there is also in patients who have long-term use of heparin, they have a risk of osteopenia. Low molecular weight heparins, it's the same sort of activity, except you have more anti-10A activity rather than the anti-2A activities. That means that you can't really monitor anything. You can't really monitor the PTT. You can't really monitor much. If you needed to monitor these patients, you'd have to use a special assay, which is the anti-10A activity, which only a few labs carry. These are smaller molecule drugs, so there's less binding to circulating or cellular proteins, which gives them a more predictable dose response. They have better bioavailability at lower doses and a longer plasma half-life. So all of that makes them really, really good for outpatient bridging. So you only have to get the patient's weight to determine how much you need to give them. And up to 190 kilogram patients, you can basically use the weight, okay, to calculate how much they need. You don't need any lab monitoring. They have a better half-life, so you can order it daily or BID. And there's a slightly lower risk of HIT. So that's perfect. The cons, however, is that the patient usually has to pay for it if it's just bridging, and it is very expensive, and not all medical plans, like private medical plans, will cover for it. And if the patients are over 190 kilograms or have a creatinine clearance less than 30, you're not going to be putting them on this. These are the alternatives that I was talking about. These are very expensive and new ones coming out. So there's fondaparinux, which is marketed as a Rixtra. It's a heparinoid drug, so it has more anti-10A activity, or more selective anti-10A activity. There is a very low risk of HIT, and there's no antidote known for it. And the pure anti-2A activity drugs, the direct thrombin inhibitors of patients with a history of HIT, the newest ones are gabatran and lepuridin, which is that drug that's boiled down from the leech sucking chemical, and dagibatran, which is an actual quite interesting, and actually Dr. So mentioned this to me. This is being used in the orthopedic surgery floors, mostly on sort of trial basis right now in Canada. It's an oral anticoagulant, and it actually has, it's showing in preliminary studies that it has a better activity or prophylaxis against DVT for hip surgeries. So let's talk about the risk of hemorrhage of patients on undergoing procedures. So of course it's patient dependent versus procedure dependent, right? So patients, these are sort of the list. I'm not going to read through all of it, but these are sort of the list of risk factors that put patients for increased risk of bleeding, give them put them at increased risk of bleeding, sorry. Okay, and then procedure-wise, so of course it depends on the type of procedure. Obviously, a cystectomy is going to have a higher risk of bleeding than, let's say, a trus biopsy, right? Depending on the patient, of course, but generally, that's the thinking. And for open surgeries, it's not, the question isn't so much as will they bleed, but So that's sort of not what I'm going to be covering too much, because those patients you'll have to take on an individual basis. But really we'll be looking at outpatient procedures, because those are the ones who will need their bridging and all of that and managing that. So just running through risk of hemorrhage for restarting your anticoagulation. So it depends on your approach. So MIS versus open, the length of the procedure. If it was more than 45 minutes, those patients have a higher risk of bleeding once you restart their anticoagulation. And amount of blood lost during the surgery, as well as hemostatic agents used, okay? Overall, however, interestingly enough, all this, kerfuffle about bridging and all of that, all of the studies, or most of the studies that have been looking at peri-procedure anticoagulation management have all shown that the risk of hemorrhagic complications is actually about the same or even higher than risk of thrombosis events. This is one such study that came out in the Archives of Internal Medicine in January 2008. It was quite a big study. It was prospective observational cohort study with looking at more than 1,000 patients on warfarin, with 1,293 interruptions of warfarin therapy over a 2-year period for procedures which were mainly outpatient, so colonoscopy, oral or ophthalmological surgeries. They looked at clinically significant hemorrhage within 30 days of interruption, as well as whether there were any thromboembolic events. Outpatient bridging therapy was given for 108 episodes, or about 8.4%, okay? And there were no thromboembolic events. However, there was a 13% rate of significant bleeding complications. No bridging therapy was given for about 1,185 episodes, and there was about an equal risk, if not just slightly higher risk, of a bleeding complication than a thromboembolic event. So let's talk about more urological stuff, more outpatient procedures. So what about the tress biopsy?
Can you just go back?
Yeah?
From a risk-benefit point of view, you have 13% significant bleeding versus 0.6% thromboembolic event. Which would you choose?
So this is what we're talking about, and whether patients, we should really be looking at these bridging therapies for the tress biopsies. So we're going to talk about, for these common procedures. So that's why a lot of people are saying, well, I'm not going to bother with this, I'm not going to bother with that. But I think you have to really, in these patients, they weren't really stratified according to high risk versus low risk for thrombosis,
But we're in a situation where every patient coming into the hospital is going to be treated with heparin.
Mm-hmm.
Just because of the VTD issues. So as surgeons, what do? I mean, our backs are up against the wall. From a medical legal point of view, if you don't bridge or take this precaution and the patient has a PE, how are you going to, are we in some form of medical legal risk situation?
Well, the literature is sort of back and forth, right? I mean, generally when you're looking, so if we're looking at the no bridging group, it's about the same. The risk is about the same, bleeding versus thromboembolic events. But what we are doing, so at the beginning of the talk, we were talking about risk stratifying patients into high, moderate, low risk. I think we can basically interrupt the warfarin therapy on the low risk patients without really any worry about thromboembolic risk. If they are high risk, though, I think if the patient does develop a PE and they're off of their anticoagulation and, their surgical hemorrhage risk was not very high, I think you'd be caught with your pants down if you were called up.
If you go back one slide,
Mm-hmm.
overall studies perioperative anticoagulation show that rates of post-operative hemorrhage are at least as high. Okay, yeah,
At least.
That's saying that it's almost the same.
No.
Actually, you're showing it's 20 times higher.
So this is one study looking at patients who were, so the two groups, right? One who received outpatient bridging and the other group that did not. So you're looking at the thromboembolic events. So if you look at this one, there's a 13% risk of bleeding complications, but no risk of thromboembolic events. Now again, this study did not look at stratifying patients into those low, moderate, or high risk groups for thrombosis. But they were undergoing outpatient procedures.
Has there been a meta-analysis?
No, there have not really been any good meta-analyses.
Tons of randomized trials, they would usually combine these into a conference.
Yeah. So let's look at outpatient urological procedures. So looking at trus biopsies. Now, generally, I don't know, Dr. Rowley, what we do here. I think we stop the anticoagulation before trus biopsies here at the hospital.
Definitely, and usually aspirin is convenient. Occasionally, if we're from away, it's drugs, something like aspirin.
Right. So Dr. Rowley basically said that we, on warfarin, patients are stopped, for anyone who's listening out there. Warfarin, we stop the anticoagulation. Aspirin, sometimes depending on their risk, they will be kept on aspirin, but generally they are asked to stop their aspirin before their trus biopsy. So there was a study back in 2007 from the same department in the UK, looking at, they basically surveyed urologists as well as radiologists who were doing trus biopsies and to figure out whether they were stopping or advising patients to stop anticoagulation, and most were. But this study came out. This was back in 2000, and this was in 2005. And there have been some other ones which have been smaller, but this is the largest one, looking at whether we need to stop the anticoagulation. So they looked at 1,000 patients, or over 1,000 patients, undergoing trus biopsy. They were given a survey to fill at day 10. There were 1,000 respondents, 49 of which were on warfarin, 220 on aspirin, and 731 on no anticoagulation. They noted 18 or 36.7% of patients on warfarin versus 440 or 60.2% on who were not anticoagulated had hematuria. So there was a higher bleeding risk in patients who were not on warfarin. About 8.2% who are on warfarin had hematospermia versus 21%. And 14% of patients on warfarin versus 13%, which is about the same, had rectal bleeding, but not clinically significant. There was no association between the severity of bleeding and anticoagulation, so what the INR was at the time. Okay, so there's some evidence to say that it is not necessary. Looking at TERPs, the evidence is quite equivocal. These are, again, relatively small studies when you're looking at the patients who are on long-term anticoagulation. There was a 1998 study from the British Journal of Urology showing 11 patients who are on long-term warfarin undergoing 12 TURPs. I don't know what was going on there. And had unfractionated heparin bridging, 200 versus 220 patients during the same time who had no anticoagulation undergoing TURPs. The average gland size was mentioned as 23 cc's, but there was no mention of how much tissue was resected. And their transfusion rate was about 10% for both groups. Another Journal of Urology article looked at 20 patients on warfarin with bridging versus 20 patients who were not anticoagulated undergoing TURP. They basically resected about 26 grams. There was no difference in transfusion requirement, but for both groups, their transfusion requirement was about 20%. And patients who were on bridging had longer hospital stays due to delays in removal or reinsertion of catheters for bleeding. So, I think doing a TERP on an anticoagulated patient is probably not a great idea. And what about the new laser prostatectomy, the green light laser, the KTP, which is a new 80 watts, right? So there have been several small studies, and I'll quote the study later on again, because it's the most recent one, looking at patients who weren't, who were kept on their anticoagulation, so the 36 patients on warfarin versus 92 non-anticoagulated patients. They resected, they think a pretty decent size. Gland size was 60 cc's, and they said that all the tissue was resected down to the capsule, but there was no significant difference in the blood loss and no transfusions. Oh, and just a little experience in Calgary, where they're using the KTP laser to do about 50% of their TURPs. They actually keep their patients completely anticoagulated, and the patients usually they still keep them overnight sometimes, those patients, and leave them with the catheter, but most patients go home without the catheter. So what about HOLEP? Well, the biggest study is out of McGill by this group, Elilali, looking at HOLEP. So this they were talking about patients who are undergoing HoLEP, and they're saying that you don't have to stop the anticoagulation. However, when you dig a little bit more into the details, it's kind of questionable a little bit. So they had 81 patients on oral anticoagulation undergoing HoLEP. So 14 did not stop their anticoagulation. 34 were bridged with therapeutic doses, and 33 withheld their anticoagulation temporarily without bridging. They resected about 55 grams. The mean enucleation time was about 90 minutes and morcellation time about 20 minutes. And they had 8 patients, or only 10% of patients needed transfusion within 2 to 5 days post-op. But their average requirement for blood was about 4 units, which is pretty significant. There were 2 patients who were fully anticoagulation out of this group, 2 out of the 8, and 1 had a mucosal bladder injury, which they accounted for their blood loss. 5 of the patients were bridged and 1 without bridging, but there were no major thromboembolic complications. So it said that it can be done without stopping the anticoagulation, but with some risk. What about lithotripsy and ureteroscopy? Well, this is the most recent article about this in April 2008, the Journal of Urology, looking at 37 anticoagulated patients versus 37 controls. 14 of those were on Coumadin, 5 were on Plavix, and 18 on aspirin. And they didn't find any difference in thromboembolic or hemorrhagic events. There was no difference in, no patient had to stop the procedure because of visibility or anything like that. There were no transfusions that were necessary, and their stone-free rates at about 1 month were about the same. So it looks like it's, you can do ureteroscopy and laser lithotripsy on patients who are anticoagulated. What about PCNL? So the same group looked at 27 patients undergoing PCNL. 16 were on warfarin with bridging therapy. 1 was on enoxaparin, just chronically not on warfarin. 9 were on Plavix, and 1 was on cilastazol, which is a PDE3 inhibitor. Outcomes showed 7% had significant bleeding. 1 was on Plavix and 1 was on warfarin. And actually they blamed those, the one on Plavix actually needed angioembolization for a lower pole vessel and required 5 units. The patient who bled and was on warfarin actually went home and took the wrong dose of warfarin. He doubled up his dose or something, and had to be admitted for clot evacuation, but required no transfusion. And only 1 patient had a DVT or PE on post-op day 4, and they needed unfractionated heparin and as well as an IVC filter, but all were stone-free at 1 month. So there is some risk with PCNLs, so depending on their risk of thrombosis, really you can consider doing a PCNL without stopping their anticoagulation. Of course, for emergent surgery, you have no choice, right? You stop your warfarin, you give vitamin K to reverse, or you can give FFP. You check the INR pre-procedure, and you can use protamine if you needed to reverse your heparin. There's no antidote for low molecular weight heparin, however. So we'll quickly run through antiplatelet management. So when we talk about antiplatelet agents, we're talking about thromboxane A2 inhibitors, such as aspirin or ibuprofen, ADP receptor antagonists, such as the thionopyridines, that's the Plavix and Anticoagulation. And those are the real ones that you'll see as an outpatient. The rest, like the PDE3 inhibitors like Persantine and Agrinox, you'll see some patients come up on it, but mostly it's going to be these ones, and all the studies really look at these ones. And these are basically for patients who have acute coronary syndrome, so you shouldn't really have to deal with that. So both of these agents inhibit platelet aggregation irreversibly. Aspirin inhibits the COX-1 enzyme, which prevents formation of the prostaglandins and thromboxane A2. Plavix or Anticoagulation binds to the P2Y12 platelet receptor, and which prevents binding of ADP and therefore platelet aggregation. And the effects last about 7 to 10 days after stopping the drugs. This is just a schematic. So your Plavix basically binds onto the receptor, the ADP receptor, preventing platelet aggregation, and aspirin basically works by binding or inhibiting the COX-1 enzyme. Okay, and there are common indications for the use and in the prevention and treatment of cardiovascular diseases such as stroke, MI, peripheral arterial disease. However, risk stratification is quite difficult. Sorry, for patients can be loosely stratified into 3 main areas again: low, intermediate, and high risk. Low risk would be people who are taking aspirin just, for the heck of it, for the primary prevention of coronary artery disease. So if they have diabetes or hypertension, it's, recommended that they're on the low dose aspirin. If it's intermediate risk, those are patients who've had an MI or a previous stroke, and they're on aspirin to prevent a second occurrence. So in these patients, aspirin actually decreases risk of stroke by 25% and the risk of a cardiovascular event by 21% in the long term. If they are put on aspirin and Plavix, the risk of MI or stroke decreases by another 20%. Patients who are at high risk are patients who've had a recent MI or stroke. That's usually within the last 3 to 6 months. And patients who've had a recent insertion of coronary stents. Okay, so these stents, you'll hear them mentioned DES stents or drug-eluting stents. These are stents that secrete sirolimus or paclitaxel, sort of fuse, I should say, and bare metal lumen stents, so BM stents is what you'll see on your cardiology consultations. So in terms of management for elective procedures, for the low-risk group, temporary interruption is deemed safe. Just stop the drug 7 days prior to the procedure and restart when the patient has a very low bleeding risk. For intermediate risk patients, you can consult with the family doctor, the internist cardiologist, to assess the risk. And then, generally you can interrupt and then for 7 days before and then restart with adequate hemostasis. For high-risk patients, though, you should get an internist or cardiologist involved. These are patients, again, recent MI or stroke or cardiac stent was recently inserted. So I'll talk just briefly about cardiac stent thrombosis because it still comes up. Dr. Au had mentioned it back in 2007. He did a whole grand rounds on it, so I'm not going to touch too much on it, but just for the residents and everyone to be on the same page. So, sorry. So atrial fibrillation, so that would be in the first part of the talk when we're talking about that those are patients who are going to be on warfarin and all of that.
No.
So
I'm talking about risk in this group. Where are you putting the AF on risk? Intermediate?
So patients who, it depends on what are they on? Are they on aspirin or are they on warfarin? Are you talking about?
Be on any one of those combinations.
Okay.
Well,
So if it's a patient who has not had any stroke and they have atrial fibrillation and they're taking warfarin, let's say, they would be basically in a sort of intermediate risk, low to intermediate risk. For patients who have had a stroke, also have atrial fibrillation. So if it's a recent stroke, then they're going to be high risk. If it's within, like a secondary prevention, it is in the moderate risk. So back to cardiac stent thrombosis. So the highest risk is until the endothelialization of the lumen of the stent occurs. That's usually longer in the DES stents, so that's up to about a year, okay? So there's a 0.5 to 1% incidence of thrombosis, most within the first month. So that's about the same for both the bare metal and the DES stents. There's a 0.7% risk of thrombosis at 1 year follow-up for the DES stents. So there is a continuation of risk with the DES stents up to a year. There's an increased frequency of late thrombosis, so more than 30-day thrombosis with the DES stents, and that is, again, because of the longer time to endothelialize. So the combination of aspirin and Plavix is essential. So, okay, it's only 0.5 to 0.1 or to 0.7% risk, so who cares? Well, it's because the post-thrombosis mortality rate is about 45%. So if they thrombose, they're going to die. So there's a 50-50 chance, okay? So this is just looking at over 2,000 patients who had DES stents. They were pre-treated with aspirin and either Plavix or Antiplatelet. They continued their combination treatment for at least 6 months for the sirolimus and at least 3 months for sirolimus and at least 6 months for paclitaxel. They looked at their outcomes at 9 months, okay, so just the risk of, the rate of thrombosis. So about 1.3% of patients had cumulative stent thrombosis, 0.6% were subacute, 0.7% late thrombosis, but 45% of 13 of the patients died. Okay? And the most important risk factor that they found for thrombosis was premature discontinuation of antiplatelet therapy. So that brought out the 2007 ACC/AHA guidelines, okay? And this is what Dr. Au had mentioned in his previous talk, so I'm not going to dwell too much on it. So the recommendations for this is for elective non-cardiac procedures, you want to defer those procedures until you've completed the following antiplatelet durations. So bare metal stents, 4 to 6 weeks, drug-eluting stents, 12 months. And you want to continue aspirin throughout your perioperative period as well. For urgent or emergent non-cardiac procedures, you can stop the Plavix, but continue the aspirin throughout the perioperative period, and then restart Plavix as soon as possible. That is when your hemostasis is adequate. Okay? There's no evidence for any bridging with warfarin or the glycoprotein antithrombotics. Okay? So looking at the risk of hemorrhage on these drugs, most of these studies, they're small. They're mainly based on aspirin. I have a few studies that talk about things done on Plavix. We'll go from here. So for trust biopsies, there seems to be minimal risk on aspirin. So BJU article in 2003 did a retrospective study looking at 36 patients on low-dose aspirin, and 141 patients who had no antiplatelet therapy. They underwent sextant biopsies, and there was no increase in self-reported bleeding complications and no major bleeding complications. Okay, there was a randomized controlled trial, not blinded obviously, in Urology 2007, looking at 200 consecutive men taking low-dose aspirin and undergoing prostate biopsy, and they were sort of randomized into 3 arms. Patients who were not going to discontinue their aspirin, patients who discontinued their aspirin and were bridged, and discontinuation of aspirin without bridging. There was no difference in the frequency of bleeding complications. However, the median duration of hematuria and rectal bleeding were higher in the groups that did not discontinue their aspirin and the ones that were bridged. So there was a slightly bleeding, but of course these were not very significant. What about TURBTs, TURPs, open prostatectomies? Well, there was this trial in 2007, about 120 patients on aspirin referred for these 3 procedures. Aspirin was withheld 5 days for surgery. However, they were randomized to early aspirin initiation. That means within 24 hours of discontinuation of their continuous bladder irrigation, or late, so more than 3 weeks. Okay, so it's not patients who were continuously on aspirin, but they were randomized to restart the aspirin earlier. They looked at pre-discharge hematuria requiring CBI reinitiation and late hematuria requiring admission. There was no significant differences between the 2 groups or amongst the surgical procedures. However, in the early initiation group, very funnily enough, 2 had MIs 2 months postoperatively, and 1 had a stroke 3 weeks post-op. So the early initiation of aspirin did not increase bleeding risk for TURBTs, TURPs, and the open prostatectomies. So you can consider it in high-risk cardiovascular patients. So what about Plavix? So again, few small studies. I think a lot of people are afraid to try this. The same study that I quoted before for the KTP laser also had 9 patients on Plavix. So they used an 80-watt KTP laser, average gland size 60 cc's, and again, no transfusions were required. And then there was no difference in the bleeding between the both groups. The other study that I quoted before on the ureteroscopy and laser lithotripsy for intrarenal stones. Again, the 2008 review by the Turner Group. So they had 5 patients who were on Plavix. And again, no difference in stone-free rate, intra-op or post-op complications, bleeding or thromboembolic complications. So those are all small numbers, right? So what can you draw from that? I think a lot of people are afraid of keeping patients on their thienopyridines for their operations. And really, if you're thinking of keeping a patient on their aspirin, you can do it if it's an outpatient procedure, depending on their thrombosis risk, or you can basically do it for the most part. So just to quickly go through drugs that we should be aware about that do alter the effect of the different anticoagulants. So for warfarin, it's all of these. So aspirin, obviously any other anticoagulation medications, NSAIDs, Flagyl, Septra, quinolones, so you know your Cipro, cimetidine, anabolic steroids, so patient on testosterone, I mentioned it twice, dicloxacillin, but the other penicillins are usually okay. And amiodarone, and any of the azole antifungals. And then drugs that decrease the anticoagulation or impair the effect of warfarin, so drugs that induce the cytochrome P450 enzyme. So rifampin, cholestyramine, high doses of vitamin C or K. And for heparin, it's about the same, increased risk of bleed with aspirin, NSAIDs, other anticoagulants, obviously. With cephalosporins is in this group here, as well as probenecid. That's the one that we always use with ANSEF to increase the half-life. And then decreasing risk of bleed, so the ones that alter the action would be digitals, tetracyclines, antihistamines. Drug interactions with aspirin, I mean, you have increased risk of GI ulcers with alcohol, steroids, NSAIDs. They have a decreased diuretic effect on spironolactone, increases the plasma level of methotrexate. And in Antiplatelet, you can have impaired absorption with antacids. So in conclusion, anticoagulant and antiplatelet medications are common, use is increasing. More patients are undergoing urological procedures and are likely to be exposed to these medications or on these medications. And we need generally to be able to assess their thrombosis risk as well as hemorrhagic risk to be able to manage these, the perioperative anticoagulation. Thank you.